So we are going to the number 4 topic. The speaker is Professor Kang Liu. He's from the Kaohsiung Medical University Hospital in Taiwan. He's going to talking about overcoming challenges in cataract surgery training among residents, an Asia Pacific survey. Welcome to Professor Liu.
Thanks everyone, and thanks our mentor in the past year, and as well as our president from Taiwan Ophthalmology Society. I'm Kang Liu from Taiwan. Today I would like to share the result of my project, Overcoming Challenge in Cataract Surgery Training among Residents. We know that mastering skill is important for the career development. Most of the surgery was performed under local anesthesia, which make the senior surgeon not comfortable to dedicate the surgery to the patient, to the resident. And the single mistake can be very serious. And we know that medical knowledge can be assessed via the board examination, but surgical skill is very hard to evaluate. So try to identify the obstacle in cataract surgery training for residents, and then maybe find some way to improve the training method. We design an anonymous questionnaire consisting of the 35 questions, and thanks to my charismatic help me to distributing this survey, and finally we got 252 responses. Regarding the simulation training, most residents have the opportunity to animal simulation training. Only 15% have VR training experience. Importantly, 16% do not have any simulation training at all. Most respondents consider the animal simulation training to be most beneficial. When asked about the effectiveness of simulation training, over 80 gave a score of 5 or higher, indicate a positive recognition of simulation training. Nearly 80% have their first cataract surgery exposure by the second year of residency. Over 90% perform their first cataract surgery on unconscious patient, which result in a significantly higher stress level. The average stress score was 6.4 out of 10 unconscious patient, but decreased to 3.9 when the patient was unconscious. This indicated the conscious level reside in a significantly higher stress during the training on conscious patient. The most commonly first step allowed to be performed was viscoelastic aspiration and the IOL injection. The least commonly dedicated first step is nucleus cracking. The nucleus cracking was considered the most challenging step regarding this of the residency stage. In terms of the specific surgical situation, more than 50% had the opportunity to manage hard and mature cataract, PC rupture, when leakage require corneal suturing, and a small pupil. Most of the respondents expressed the need for more emergency complication management and the proper mental guidance about detailed surgical tips and the detailed surgical steps. The number of complete cataract surgery performed by residents show a polarized pattern. Most had under 20 or over 200. This reflects unequal training opportunity and the training environment. About the confidence in surgical skill, remain moderate. The average score is 5 out of 10, either during or after residency. This may suggest the residency training did not significantly improve the surgical confidence in surgical skill. Over 50% expressed the anxiety related to the surgical skill during training. Over 90% report there's no opportunity to do a training abroad. Most agree that a short-term cataract surgery training program is important for the mature. The average score is 7.1 out of 10. So the major issue identified is a higher patient expectation, which make the senior surgeon reluctant to dedicate surgery to the residents, and the local anesthesia limited practice number. And the most preferred method to improve the surgical skill still remain the more clinical opportunity. So in conclusion, the surgical training in cataract is still based on the apprenticeship model, and the stress and the anxiety are common, especially on the conscious patient, and the confidence in surgical skill remain moderate, even during or after training. And the simulation-based training considered beneficial but not equally accessible. And there is a lack of standardized assessment for surgical competency. Based on the result, we suggest establish a standardized surgery curriculum, and the short-term training program may be important. And expanding simulation-based training may improve the skill, and improving the mentor training system, and implementing a structured surgical training requirement with a minimal surgery number and the case large book. Finally, I would like to thank my classmates help me to finish this study and make it possible. And this is Taiwan, from Kaohsiung, is in southern Taiwan, and thank you for everybody, and welcome to Taiwan this summer for the master class.
Thank you, Professor Liu. Can I ask you a question? Oh, any question from the audience? I'm so sorry.
Okay, thank you very much. I really appreciate this project. And then I see the result that most of the register was get stressed when they do patient with conscious patient. But the fact that most of the patient that we do, especially in the cataract surgery, maybe more than 90% was done by conscious patient. So what do you suggest for that? Because sometimes if the patient feels stressed, and then we can give the unconscious medication. So we should do the doctor also give that medication or something like that. Do you have a suggestion for us? Thank you.
Thank you for the very great question. I think it's a major problem especially for the initial stage of the resident. For me, like when I perform my first surgery, I shake all the time, and I think that's because now we do the surgery under local anesthesia, so it's very hard for the surgeon or mentor to delegate the surgery to the resident, and the single step mistake can be very serious, as everybody knows. So I think maybe we can start from the simulation-based training and make every step very familiar, especially like VR. I think with the advancement of VR technique, maybe we can do more real experience about the surgical skill, and then step by step to the surgery, and from the most easiest part, and then to the hardest part. Yeah.
Yes, just a comment. Congratulations, a very comprehensive study. I think you can take this forward by publishing this data, because it's actually first-hand information from all the colleagues from the region. So I think you should take it forward and publish. Yeah.
Okay, you have a question from the boss.
My question is, when did you train your residents by yourself? I mean, your first year resident or second resident?
For me, actually, I like the second. So my first exposure to the
which step you let the resident?
IOL injection, and I'm the under 21.
Okay.
All right, thank you very much.